In this section, we will discuss hypersensitivity. In this section of the lecture, we will cover hypersensitivity. So hypersensitivity could be characterized as one of the three failures of the immune system. It's not really correct to think of hypersensitivity in terms of a failure. It's more correct and might be easier on your studying if you think of hypersensitivity as an inappropriate response. Hypersensitivity is the immune system doing its job. It's just doing its job against an antigen that you really don't want it to do its job against. So in that aspect, we won't think of it as a failure because it is working. It's just working against something that you don't want it to work against. So with that in mind, let's talk about the different types of hypersensitivity. Remember, this requires a pre-sensitized state. This is a memory type of response. It can range from causing discomfort to being extremely lethal, depending on the antigen and depending on the body's response. And it's divided into four types. These four types can all be differentiated by their mechanism and or the speed of the reaction. Now type 1, just to kind of give you a broad overview, type 1, its claim to fame is that it's IgE mediated. This is the classic hypersensitivity, immediate type hypersensitivity that you're used to thinking about. Allergies, anaphylactic shock, that kind of thing. Those all fall under the type 1 heading. Type 2 is known as the antibody mediated hypersensitivity. This is direct cytotoxicity. This is antibodies binding directly to tissues and mediating their destruction, and we'll get into that. Type 3 is the immune complex mediated hypersensitivity. This is the one that's associated not so much with direct killing, but an indirect tissue destruction, and again we'll go into detail on that. Type 4, its claim to fame, is the delayed type hypersensitivity, and that kind of distinguishes it from type 1, where type 1 is immediate response to an allergen. Type 4 is a delayed type response, and it's the only one of the four hypersensitivities that's mediated by T cells. That's another distinguishing factor for type 4. So type 1, again, type 1 is our classic allergy response. An antigen cross-links IgE on presensitized mast cells and basophils and triggers release of vasoactive amines such as histamine. If it's a systemic type of release, then we get anaphylactic shock, right? Again, this is a preformed antibody type of response. It's a memory cell type of response, and that's what leads to the rapid reaction. That's why it's called immediate hypersensitivity. So examples of type 1 hypersensitivity or examples of allergens to which you might see type 1 hypersensitivity are things like pollen or dust mites, and in case of anaphylaxis, things like food allergies. So here's an example of how this happens. The first exposure to the allergen we see on the left, that's the sensitization step. We have here a normal immune response, exactly what we've talked about when we talk about antigen presentation to T helper cells. In this case, we have the allergen, which is represented by the heart, oddly enough, because nobody loves allergies. But in this case, we have this allergen being recognized by the B cell, internalized, broken down, and presented to the T helper cell, just like it would any other type of foreign antigen. In this case, we happen to have this T helper cell that's specific for this allergen, and it will respond. It will start to make cytokines. It will cause that B cell to class switch to, in this case, an IgE. And remember, we said that mast cells and basophils loved to bind IgE. They have the surface receptors that are IgE specific, or IgE Fc receptors. And so when they see the Fc portion of an IgE antibody, they bind to it and they stick to it like glue. This is the sensitization step. This is critical for understanding why type 1 happens so fast. So at the end of this first exposure, at the end of this primary response, you have these mast cells and these basophils which are glued onto these IgE molecules that are specific for that allergen. Therefore, the second time you get exposed to that allergen, when you have a repeat exposure to that allergen, those IgEs that are sitting on the mast cell, for example, will bind to the allergen, and you can see that it causes cross-linking over on the right. You can see that that allergen will cause cross-linking of the IgEs that are bound to that mast cell. When you have this cross-linking, that activates the mast cell and causes degranulation. What's in these granules? Again, things like histamine. So picture this mast cell in your nose with these IgEs already bound to it. You breathe in an allergen like a pollen that then causes this cross-linking, and then the mast cells in your nose degranulate. Well, what happens? you get vasodilation in the nose. Now you have that runny nose, you have the difficult breathing, you have the boggy turbinates that are classic for this type of hypersensitivity, this allergy, seasonal allergies, hay fever, that kind of thing. This is how it happens. Again, it's a normal immune response. It's the body doing what it's supposed to do. It's just doing it against, instead of a pathogen, it's doing it against an allergen. Now, picture this as a basophil circulating in the blood. Same thing. It gets exposed to this allergen. It's got these IgEs that are already on its surface that are specific for that allergen. They cross-link, degranulate. Now you have, instead of local degranulation, you have systemic degranulation in the circulatory system. You get systemic vasodilation. There goes your anaphylactic shock. Again, all normal immune response. It's just the fact that this is not a pathogen, it's an allergen. So, a question for you. Treatment with which of the following would eliminate IgE-mediated mast cell degranulation? A. Pepsin only, B. Papain only, C. Pepsin and papain, or D. Neither pepsin nor papain? And the answer here is C. Pepsin and papain. Why both of them? Well, let's think about what they do. Pepsin, remember, after the digestion of the antibody, destroys the Fc portion and leaves that Fab'2 fragment intact. So the Fab'2s can all bind to the allergen. You can get binding. You can even get aggregation or agglutination of the antigen or the allergen in this case. But since the Fc portion is destroyed, they're no longer attached to the mast cells and basophils. So that would inhibit degranulation, correct? So pepsin would do it. How about papain? Papain, remember, cleaves at the hinge region, and at the end of the day you have two Fab fragments and an Fc fragment. Well, that Fc fragment will bind to the Fc receptor on the on the mast cell or the basophil, and the Fab fragments will bind to the allergen. But since there's no agglutination, there's no way for those Fab fragments to cause cross-linking, even though the Fc portion of the antibody is still intact. Nothing gets cross-linked, and therefore, again, no degranulation of the mast cell. Therefore, the answer is C. Both pepsin and papain would eliminate it. Another question. As an intern, you are paged at 2 a.m. because a 76-year-old woman cannot sleep. Wanting to avoid over-sedation, you decide to give her a diphenhydramine to help her sleep. Knowing that diphenhydramine is an antihistamine, which of the following responses of the immune system is consequently affected? Is it A. T-cell activation, B. B-cell activation, C. Antibody titers, D. Vascular permeability, or E. NK cell activity? And the answer is D. Vascular permeability. Again, if you have an antihistamine, then you're going to inhibit the effects of the histamine, which is to vasodilate. So vascular permeability would be affected. Moving on to type 2 hypersensitivity, we call this again the antibody-mediated hypersensitivity. This occurs when you have an antibody that's specific for a cell surface. For example, you have an antigen on the surface of a cell, be it a basement membrane or an antigen on the surface of a red blood cell that you happen to get an antibody against. This is typically an IgM or IgG antibody against a self-antigen. We also see haptenogenic effects with type 2 hypersensitivity. Remember that haptens are small molecules that the immune system doesn't recognize in and of themselves, but when they attach to larger carrier proteins, then the antibodies can see them. Well, sometimes those antibodies will, once they become specific for that hapten, or once specific antibodies will bind to that hapten carrier conjugate, they can become sensitized to attack the carrier even in the absence of the hapten. If that's the case, then you have a type 2 hypersensitivity picture. Cell destruction in this case occurs via either complement activation, ADCC, or phagocytosis. Some examples of type 2 hypersensitivity include incompatible blood transfusions, hemolytic disease of the newborn, or autoimmune hemolytic anemia. Some examples against cell surface receptors, examples of type 2 hypersensitivity here would include things like Graves' disease or myasthenia gravis, where you have, again, antibodies binding directly to tissues. So here, to review the mechanisms by which antibodies can mediate cytotoxicity, we have on top an example of ADCC. Remember, those antibodies will bind to surface antigen on the cell. The Fc portion of the antibody will then be recognized by an Fc receptor on the granulocyte, which can then degranulate and destroy the cell. On the bottom we have complement. Remember, With the classical pathway, if you have antibodies binding, they can initiate the complement pathway. That complement pathway will then ultimately lead to cell destruction. Another review slide just to again point out the ADCC, antibody mediated. With type 2 hypersensitivity, we have antibodies binding to surface antigens. This time, instead of them being foreign antigens, they would be a self-antigen. The antibodies then stimulate the granulocytes, NK cells, neutrophils, eosinophils, macrophages to degranulate, release lytic enzymes into the environment, and destroy the target. So blood grouping is a good example of how this might work. Remember, the ABO system is made up of antigens that are found on the surface of red blood cells, and the boards love to test on the ABO system and on the Rh factors. So it's important to keep in mind what's going on with this system. So on the left column we have genotypes, in the middle we have phenotypes, and on the right we have serum antibodies. So we're talking about two different concepts here. The antigens that are expressed on the surface of the red blood cell and antibodies that you would find in the serum of those people. For example, let's look at genotype. We'll start in the middle and do genotype AA or AO. If you have that genotype, then you have the gene to express A antigen on the surface of the red blood cell. So you express an antigen which is termed A antigen on the surface of your red blood cell. Therefore, your body would see that as a self-protein and would not make antibodies against it, right? It would be tolerant. However, there's no B antigen expressed on the surface of that red blood cell, only A. So any B antigen would be seen as by your body as foreign. Therefore, you would make anti-B antibodies. So people that have type A blood, that means that they have A antigen expressed on the surface of the red blood cells, and they will have anti-B antibodies in their blood. Vice versa for type B. If you have BB or BO, that's type B blood. Okay? What does that mean? You express the B antigen on the surface of your red blood cells. That means that you would also make anti-A antibodies. Your body would see A as foreign. Okay? If you're AB, that means you will express both. These are codominantly expressed. So you'll have both A antigen and B antigen on the surface of your red blood cells. If you have both of the antigens on the surface of your red blood cells, then your body would not recognize either of them as foreign. Therefore, would not make antibodies to either one. That would be counterproductive. So in the serum of people with type AB blood, you will not find anti-A nor anti-B antibodies. Now, O is just the opposite. O is not an antigen in and of itself. There's no such thing as O antigen. Type O people, or people with type O blood, have no ABO antigens expressed on the surface of their red blood cells. Therefore, they would recognize either A or B as foreign. So in their blood, they will have anti-A and anti-B antibodies. So there you have it. You go by the type, and you can specify what antigen is on the surface of the red blood cells and what antibody would be in their blood. If you can do that, then you can answer questions about ABO blood grouping. The Rh factor comes into play just for the sake of simplicity, and what you need to know on the boards, you're either Rh positive or Rh negative. So if you're type A positive, that means you express A antigen on the surface of your red blood cells. It means that you express the Rh antigen on your red blood cells. So if you express the Rh antigen, would you have anti-Rh antibodies? No, because those would be self-proteins, right? However, if you're A negative, that means that you have A antigen, but you lack the Rh antigen. If you lack the Rh antigen, then of course you would see it as foreign, and you would make anti-Rh antibodies. So that's how blood grouping works. A good example of blood grouping disease-wise is hemolytic disease of the newborn. This is a good indicator, or a good example of how we use immunology. So, what happens with hemolytic disease of the newborn? Remember, during the first pregnancy, we have the fetus and the mother with an Rh mismatch. The mom has to be Rh negative, the baby is Rh positive. How does the baby get Rh positive? Well, from the dad, of course. So during this time, during this first pregnancy, there's no problem, right? The mom's not attacking the baby. Why? Because the blood doesn't mix, right? Mom has not been sensitized. Mom's never seen Rh antigen before, so she's not making antibodies against it. There's no mixing, so everything's fine. That baby will come out just fine. However, during the birthing process, the mom will be exposed to this baby's blood, will be exposed to this fetal red blood cells that have Rh antigen on them. Therefore, because the mom's body will see that it's foreign, she will make an immune response. She will have memory B cells at the end of this response to Rh factor, anti-Rh IgGs, right? Not a problem now because the baby's out. However, if the mom is to get pregnant again and has, again, a baby that's Rh positive like the first one, now she's got memory cells to this Rh. She makes IgGs to this Rh. And remember what we said about IgGs. Those things can cross the placenta. So they'll get into the baby's bloodstream and they can attack the baby's red blood cells. And this is what leads to hemolytic disease of the newborn. And in the severe cases, the most severe cases, the strongest responses, that can lead to fetal demise. So what do we do about this? Well, we give the mom RhoGAM, right? And what's RhoGAM? RhoGAM is actually an anti-Rh antibody. And the theory goes like this. If you give the mom during the first pregnancy RhoGAM before the baby is born, and then immediately after the baby is born, you give her these anti-Rh antibodies that are circulating in her blood before she gets exposed to the baby's blood. And the theory is that in having these circulating antibodies, once the baby's born and that mom gets exposed to those fetal red blood cells that are Rh positive, these circulating antibodies will bind to that Rh factor and it will mask that Rh factor from the mom's B cells. So if the antibodies that you inject can bind to the Rh factor before the B cells from the mom can see that Rh factor, then the B cells will never respond. You won't get that memory response, you won't get IgG production, and that next baby will be safe. So as long as you give the RhoGAM immediately after, as well as a few weeks before the birth, then you're covered. Then you can mask the mom's immune system from the Rh factor and she won't respond. Pretty neat trick. How about this question? The paramedics arrive at the scene of a one-car accident. On arrival, they notice that the driver has been ejected through the windshield and is lying in the ditch. Unsure of how much blood has been lost, they prepare blood for possible transfusion. Which blood product should they prepare? A, AB positive blood, B, AB negative blood, C, O positive blood, D, O negative blood, or E, platelets. The correct answer here is D, O negative blood, right? Why do we want to use this? Because the O negative blood, because it's O, doesn't have A or B, right? And because it's negative, doesn't have Rh. So no matter what blood type this patient has, he will not respond, he will not cause a transfusion reaction with O negative, because even if he has anti-A and anti-B antibodies, the O that he gets doesn't have anything on it, and he won't respond. He won't make that transfusion reaction, and he won't lyse the blood that you're trying to give him. So D is the correct answer. How about this one? A 69-year-old man is admitted to the hospital for a painless lower GI bleed. His hemoglobin drops from 12 to 9 in the first 4 hours. His type and screen shows antibodies to B and antibodies to Rh. He should be transfused what type of blood? Is it A, A positive, B, A negative, C, B positive, D, B negative, E, A negative or O negative, or F, O positive? The correct answer here is E, A negative or O negative. The way we tackle this question is that we can look at what it's giving us. Antibodies to B. That means that he is either type A or type O, right? And he has antibodies to Rh. So if he's got antibodies to Rh, that means he is negative, right? So you would give him A negative or O negative type blood. Another question, a 38-year-old woman develops postpartum hemorrhaging as a complication to her first delivery. She is transfused A negative blood based on a type and screen recorded in her chart. 10 weeks after transfusion, she is found to have a high titer of anti-Rh antibodies. What caused the vigorous antibody response? Is it A, fetal Rh status, B, fetal ABO status, C, transfusion Rh status, D, transfusion ABO status, or E, IgM to IgG class switching? The answer is A, fetal Rh status. How do we come about this? Well, we know that she's transfused A negative blood. If she's got negative blood, would she have a high titer of anti-Rh antibodies? No, they wouldn't respond to A negative blood, right? So we know that it's not from the transfusion, okay? Now, as far as ABO goes, she was typed and screened. She got A negative blood. Assuming that the type and screen was correct, then you wouldn't expect them to be coming from the transfusion ABO status. So what does that leave us? That leaves us with A, the fetal Rh status. Moving on, type 3 hypersensitivity. We call this immune complex hypersensitivity. Remember that immune complexes result when antibodies combine with soluble antigen. And we have this sort of web or this network of antibodies and antigens kind of agglutinated together. Well, these are being circulated throughout the blood, and as they get larger, just because of physics, they get forced to the side, right? The blood, the flow is rushing through with the velocity greatest in the middle of the vessel and will force these interruptions to the sides, and it will either deposit them in the vessel walls or it can force them out into, say, synovial joint fluid or out into the kidneys, things like that. So these antigen-antibody complexes, these immune complexes, will get deposited in the tissues. They will then activate complement and neutrophils. This is all, again, normal immune response. Whenever you have this immune complex formation, your body tries to get rid of it, and that's the immune system's job. So complement will get activated, neutrophils will get activated in an attempt to break down these immune complexes. Normally, that's not a problem. However, in the case of type 3 hypersensitivity, you have buildups and buildups and buildups, and kind of a chronic picture of this immune complex being built up and then being destroyed. And in the process of this destruction, this constant chronic destruction, you get tissue damage. And that's that tissue damage that mediates the effects that you see from these type 3 hypersensitivities. So the reactions can be general, things like serum sickness to drug reactions. That's an example of type 3 hypersensitivity. Or there are certain type 3 hypersensitivities that are more organ-specific. An arthritis reaction to a vaccination, for example, found in the skin. Lupus in the kidneys. Polyarteritis in the blood vessels. Or rheumatoid arthritis in the joints. Let's see a picture of how this happens. Here's the diagram. Remember, we said we have antigen, antibodies kind of binding to each other, agglutinating, forming this network that gets pushed over to a tissue. For example, here we see on the right. Notice that the antibodies are not binding directly to the tissue. This is different than type 2. If this were type 2, those antibodies would be binding directly to the tissue. In this case, the antibodies are binding to that soluble antigen, but the complex is just kind of being forced onto the tissue, sitting on top of the tissue. Well, through activation by complement, the neutrophils will come in to break down this immune complex, and in the process, they'll release lytic enzymes and granules and things into the environment. Well, those granules aren't looking specifically at the immune complex. They're going to destroy whatever's around. So if they're in some type of vessel, for example, they'll destroy part of the vessel wall. If they're in the glomerulus, they'll destroy part of the glomerulus. If this is acute in the short term, that doesn't matter. Why? Because your body's very good at healing itself. But if you have chronicity, if you have this happening over and over again, you could see how that would lead to permanent tissue damage. Here we see an example of a small vessel, in this case SLE. With SLE, remember that the main hypersensitivity issue here is antibodies that bind to double-stranded DNA, which is ubiquitous, right? It's found all over your body. So the chances of antibodies finding double-stranded DNA are very common. You get this constant type of immune complex buildup. These complexes get forced, in this case, out to the vessel walls. Complement and platelets become activated. Those will then activate things like basophils and neutrophils. You get vasoactive amine production. You get vasodilation, right? So the vasodilation will happen. You can get swelling. You can get lytic enzymes from the neutrophils being dilated out or filtered out through this vasodilation, not only to the vessel wall, but to the intimal, to the things underneath, as well as microthrombus formation. So through this action, through microthrombus formation, through neutrophil chemotaxis and granular release, you get tissue destruction, and this will cause, for example, the arteritis that you can see with lupus. So here's a question to go. A 42-year-old woman is diagnosed with systemic lupus erythematosus. 6 months later, she complains of red-orange urine. Blood tests reveal elevated levels of creatinine and blood urea nitrogen. Immunofluorescence microscopy of the kidney will most likely reveal which of the following. Is it A, antiglomerular basement membrane antibodies, B, autoimmune complex deposition in the glomerulus, C, antirenal tubule antibodies, or D, macrophage infiltration in Bowman's capsule? This is B, autoimmune complex deposition in the glomerulus. Why B? Well, she's got SLE. You know that this is a type 3 hypersensitivity, right? If it's type 3 hypersensitivity, then you're looking at complexes, autoimmune complexes. If it were A, or C, where you have antibodies binding directly, well, that would be a type 2 hypersensitivity. That's not associated with SLE. Type 4 hypersensitivity, or delayed type hypersensitivity, is caused by a subset of CD4 T helper cells that are reactive to antigens, right? Again, normal immune response. In that first exposure, just like you see in type 1 hypersensitivity, in that first exposure, you have creation of memory cells. In this case, instead of being a T helper type 2 interaction, it's a T helper type 1 stimulation. So instead of getting humoral immunity, you get cell-mediated immunity. At the end of this primary response, you have memory Th1 cells that are generated. During a secondary exposure, then, you get expansion of the T helper memory cells. Those will activate macrophages, they'll activate cell-mediated type immunity, and that will lead to inflammation and tissue destruction, tissue damage like we talked about. However, this one's not immediate. Remember, the immediate from the type 1 comes from the fact that you had those preformed antibodies bound to the mast cells. Well, even though we have memory cells, remember that memory cells take a couple of days to get going. So in this one, this type 4, because it's T helper 1 and we're not having an antibody response, this is a 2 to 3 day process. We get 2 or 3 days of this T helper 1 activation and stimulation that leads to the tissue damage. So examples of type 4 hypersensitivity would be things like contact dermatitis, poison ivy, poison oak, nickel, latex, that kind of thing. TB skin test is also an example of type 4 hypersensitivity, the PPD skin test. Or transplant rejections are also an example of type 4 hypersensitivity. So this is why with a TB skin test, you go and you have them prick your skin, and then the nurse will tell you what? Come back in 2 or 3 days to let me read it, right? Again, it's a delayed type hypersensitivity. So here's an example of how you might see this on the boards. A 42-year-old scout leader reports to his doctor with an itchy rash on his right calf. He reports being on a campout 3 days ago with his scout troop. Physical examination reveals a red maculopapular rash on the outer aspect of the right lower leg. A scraping of this rash would most likely reveal which of the following. Is it A, Th1, CD4 positive T cells, B, Th2 CD4 positive T cells, C, dendritic cells, D, T-dependent B cells, or E, T-independent B cells? The answer here is A, Th1 CD4 positive T cells. This is a classic example of delayed type hypersensitivity. He's got an itchy rash on the outer aspect of his calf, happened to be on a camp out 3 days ago. Now he's got this rash. This is delayed type. This is probably a poison ivy or a poison oak. So what's the scraping going to reveal? Th1 CD4 positive T cells. So here we have kind of an overview, a pearl slide, if you will, of all of the types of hypersensitivity. So we have type 1, remember that's IgE mediated, that's your immediate type hypersensitivity, mast cells, basophils, histamine, anaphylaxis. Type 2 is your antibody-mediated cytotoxicity, antibodies binding directly to the tissue and mediating their destruction. So think things like hemolytic disease of the newborn, transfusion reactions, Goodpasture syndrome, or ITP. Type 3, this is your immune complex disease. Again, remember this isn't antibodies binding to tissue mediating their direct destruction, but more the immune system trying to break down immune complexes and in the process damaging bystander tissue. Serum sickness, SLE, Arthus reaction. Remember these complexes deposit in vessel walls and you then have complement coming in, neutrophils coming in, trying to break them down. Type 4 is our cell-mediated or delayed type hypersensitivity. Remember, contact dermatitis is a good example of this, or the tuberculin skin test. Remember, this is the only one that's mediated by T cells. This concludes our overview of adaptive immunity. In the next section, we'll discuss major histocompatibility